We realized not everybody is going to come on, but that was a large group. So welcome. We're glad to be back to doing this. We've been on a hiatus, and because I moved, and then we had conference. So life's been crazy, but we're happy to be back. And it was actually at conference that Lisa approached me and said, I have this kiddo and I'm a speech and language pathologist and I really need more input from other disciplines. And I was like, fantastic. That's a great start to our case studies. So anyway, Lisa, if you will introduce yourself, tell us a little bit about yourself, and then you can introduce your patient here.
Okay, perfect. And I assume you can't see me, right? Because I don't want to get out of this presentation.
I can see you on, I've got,
on the side.
I don't know about everybody else, but I've got the way I'm looking at the screen, I see you.
Perfect. So like she said, thank you, Carol. I'm Lisa Skinner. I am a speech pathologist. I live in the Woodlands, Texas, north of Houston. And I kind of started this whole journey like in 2017 to get into hippotherapy because of my son. I became a speech therapist because of my son who has DeGeorge syndrome. And I finally did the certification, the first certification. And now I've started to dive into it. I decided finally to just bite the bullet and get my own herd. And so I have 2 ponies and 2 horses. And then I also have now started at a PATH center, providing some therapy there. And this kiddo is at that PATH center that I'm started treating. And his mother is amazing. And so I guess I'll just jump on into Mr. Omar if everybody's ready.
Ready.
Okay. So Omar has Patau syndrome or trisomy 13, which I guess is a reduplication of a genetic of a gene. Let's see, let me get the actual definition. It is, I'll come back to him in a second, but I don't want to say it wrong. So she put it here. So, well, we'll go back. I'll get to it later because he's also in a medical journal along with 3 other babies. And I will share that also in a minute. So he is now 8 years old. He was born and the mother was told that he would maybe not even make it till a year if most of these children born with this die before the age of 1. And he has gone through a lot of issues, obviously, medically and physically. I think his skull was open when he was born. He's had several surgeries on his skull. And he's been in the NICU unit, of course, when he was born for a couple weeks. And he's had a lot of events where he's, lost oxygen, not breathing, turning blue. And he was even in hospice for 3 months. It's got GI infections, had G-tube placement, but he's out eating some puree foods, I believe. And he's got vision problem in one eye. I think the left eye he doesn't see out of, but the right eye he has vision with. He can nearsightedness, but he can see with his glasses on. And here's where it talks about he eats out of a mesh bag or about 4 ounces of pureed food by mouth. He does have safety precautions for swallowing, but he does sip water. But he generally has tube feedings as well. So he does receive all therapies. He even went to an intensive therapy. She took him to an intensive therapy for 2 weeks somewhere like Austin or somewhere, where they did all the therapies 2 weeks straight every day. the parent does anything and everything to help him. She's even the sidewalker for hippotherapy for during the hippotherapy portion of his speech. And then he's schooled at home. He's through the school district. Let's see, in terms of, the physical parts, he's walking with assistance. He'll put, one foot in front of the other. I'm going to show a video of him walking, and I'll also show a video of him on one of the horses. He's been to my barn where I have my own herd, and then he typically rides at the path center. That's where we met, and I started there with him. But when he rode at my barn, interestingly enough, on my horse, it definitely went differently. It went better for some reason. Could be the horse, could be the environment. There's a lot of factors there. He wears AFOs, uses a gait trainer. He's mostly in the wheelchair and a stroller. He can sit up when he sits crisscross applesauce. He can have trunk control. And but on the horse, we're working to see if he can stay upright, like half the arena, or get a quarter way around, that kind of a thing. But he a lot, so it causes a challenge for me to have him on the horse sometimes. Let's see, like we've gone over this, his vision, he's visually impaired. He's had several eye infections. What's interesting is his left eye is the one where he doesn't have any vision, but he turns his head to the left to see you, to look at me when he's on the horse with his other eye. He has hearing loss in both ears and does wear hearing aids. He'll pull them out and try to swallow them, she says. I haven't seen him do that, but
Can you speak up just a second?
He's
yeah, because it's like I hear you,
sure.
and then I kind of lose you.
Oh, okay. Let me turn up the volume here. And so he also there, got the volume up, sorry. He also has to have music playing every single minute. That's all he lives for, is his music. That's his motivator. And she plays it into his, so his hearing aids, it's coming through his hearing aid in ways that are different than he did a few years ago. And we just had a meeting today. She invited me to one of the meetings with the school speech therapist. He's not receiving speech therapy through school. And I asked why. So we met, and they're going to reevaluate and assess, because he's definitely changed. He's got more, he's developed a little bit in areas that he could start working more on his functional communication. So he's protesting appropriately. That I know. He's immunodeficient. Boy, I mean, this kid's got it all. He's adorable though. Let's see. A lot of medical equipment they use at home, such as suction machine, CPAP machine, feeding pump. So these are his current health issues. This was just updated about a month ago. The parent updated all of this information. So he does have febrile seizures. He'll end up in the hospital sometimes if he gets a UTI and it doesn't correct itself with treatment with antibiotics. Respiratory illness, seizures. It's just, let's see what else here. She also sent me just the plain definition of it, and I will show that to you in a minute after we get through her PowerPoint. So this is his schedule. He's in speech, OT, private speech he was, but now that private therapist has moved. He's not receiving it at the clinic. He's only receiving it with me once a week. He's getting PT, OT, he does aquatics. He has sleep medicine and pulmonary appointments, Botox injections. She says, I guess on Wednesdays. They've started that to help with the rigid, his spasticity. And this is the journal article that I was talking about. I'm going to open it. He's right here in the journal article. And this is the opening in his little head. Because he's in, these are the 4 kids, each one, and in each row, he's one of them. You have to spot him. Let's see. So mom has summarized that he's has a life-limiting syndrome, and they're just doing the best they can to keep him healthy and safe and well. And they're just continuing treatments and doing whatever they can with this medically fragile child who just keeps on developing and growing, which is really amazing. Let me see if I can open that article for you. And that is not it. Let me find it. Here it is. Are you able to see this one now, Carol?
Yes, I'm
Are you there?
seeing a journal article.
There you go. Okay. So this is the definition also, which will help. And it's associated with the mortality rate is very high. It's like 90% within the first year of life, just because of all the congenital abnormalities that increase their mortality and morbidity rate. And it's a chromosomal abnormality associated with, let me see where it says here. The third most common, which is interesting, of the type of syndrome, the syndromes where there's duplicity of the chromosomes, such as Down syndrome. And but this one is not quite as common. It's pretty rare, apparently. And he is part of this journal article here. This is little Omar. And it's interesting. So if anybody, I'm not going to read through the whole journal article for you, but I just wanted you all to see that you can look it up and look up guidelines for children with this in case anybody gets a child and needs to treat a child with this. And then, Carol, am I able to show the videos from here?
Hopefully you can. Do you have it open and down on your,
Hopefully I can. Okay, let me find them.
if you have it open, but yeah, there we go. We're seeing the pictures.
So let me open this. So this is the first that I didn't put any, I only put a surcingle and a pad. He had been doing, let me give you a little bit of background. He's been doing therapeutic writing for about, since he was 3 or 4, for maybe 4 years. And since I started there just this year, that's when I started working with him. And I just wanted to see where he was and what he was like. Now he was wearing a I don't even know the name of it. It's like it's a hard shell almost, but it's so you
A TLSO, a thoracic lumbosacral jacket, like a body jacket.
A thoracic one, yes. So that but now that she said that he's sitting up crisscross applesauce, I want to know if this is something I just want to try it without it and see where we are. I now use I think I even got it at the conference, but I've been using supports in the front so he can lean forward and rest on it and push himself up if he needs to. But I'll play this video and you'll see what I'm talking about. He's gonna flop forward. And sometimes he likes to flop backwards. Like he purposely tries to lie down, but he'll pull himself up. I also have a video of him walking. me see if I can get to it. This little box is in my way. There we go. All right. Okay. And then this is when he was at my barn. I did Jerry some pads that he laid on with this ball, and he did really well there. He sat up with the assistance was not as much when we did it with him there, and it could be it's so many different things because the environment there is lovely and outdoors and maybe like looking around. I don't know, part of it. And then the horse is a little bit different. So at the barn at Sire, at the okay, I think that's it. The barn that is at the Therapeutic Riding Center, this is the horse that he's on. It's a little fjord. The reason he's on this horse is because, and I don't think it would be the horse of my choice. Honestly, it's not the horse of my choice for him to be on, but she's got a lot of movement. I'm trying to find a better photo of him on this horsey. She's, thick, wide. She's got a lot of movement, but she's the only horse that will really tolerate the movement that he makes because he throws his body around. And so there's one other pony I would like to use him on, but we're afraid he would squeeze so hard she'd just take off. So that's where we are right now with that. So I'm hoping at some point we'll get to where we can maybe try a different horse. But if anybody tonight has better suggestions, that's what I'm here for, because I'll take anything. He's a challenge. There's also one video, if there's any speech therapists here or anybody else, OT2, I'll show you the one other video of him using his device, which is why I met with the school therapist and the mom today to discuss that somehow he had an evaluation and the mom said that he was, I'm trying to find a video, given a Toby Dynavox. And it's way too complicated, in my opinion, for him to access it. It's not in this. Sorry, everybody. I'm at least go through here. It's not in this part. It is in this part. Library. Sorry. Nope, don't want to show you my whole library of animals, but there it is.
You want music? Find more. Say more. Touch more.
So as you see,
More. More. Can you say more? Use your hand. Say more. Say more. 2 hands. More. I'll wait to see if he'll do more. Go. Okay. Use your hand. Say more. Say more. Say more.
okay.
More. Oh, there you go. Said more. We'll put more. More music.
So this device to me is device is just, to me, it's very complicated for him, and I don't know even if he needs, I don't know if he has the motor skills in order to operate. It's even difficult for me to maneuver in the side of that, the way it's set up. So I just recommended that they try to find something that's a little more simplified, like a Go Talk, with fewer options for him to maneuver and touch. Because I think he's just running his hand down it, and it just happens that more is right the line of fire where he's going. Um, so I know that mom wants him to be able to communicate in some way. So right now I've just been using buttons in therapy for him to touch, to push and have a response. But his also the other concern is that his only motivator I can find, or even mom can find, is music. So if you turn it off, then he's going to do whatever he can to request it. But it's a challenge for that, in that we can't, it's a challenge when you don't have the motivators to try to help them learn something new. So
Okay, Lisa, it was asked to please re-explain his visual impairment. As I recall, you said it's his left eye, he's completely blind, and in the right eye, he does have some vision.
yes, he's nearsighted in the right eye. They did a surgery to raise the eyelid as well to help him see. He can see out of his right eye with the glasses, but his left eye, he's blind. He can't see.
Okay, all right. So I want everybody to just kind of hold all these snapshots of information that Lisa has shared with us about Omar. And I want to backpedal just a little bit, because the way we do the case studies is we go through the diagnosis first, and then we kind of look at the patient from the different therapy perspectives, and we think about what we're seeing and what might we use as an evaluative tool to find out more about this child. And then, thinking about what treatment strategies, tools, activities we would be incorporating, and then we'll narrow it down into the horse, if that's okay with you, Lisa.
Yeah.
All right. So I was completely unfamiliar with trisomy 13. So I had to do some research to just learn more about it. So it was interesting what Lisa shared, is that this is the third most common trisomy syndrome. And we all might say, well, how come we haven't seen one? Well, as she also pointed out, 90% of them do not make it past the first year. In fact, I think 80% are either stillborn or die very soon after their birth. And so I watched a video of a family with their little girl who was way more involved than Omar is. And so the question is, is that because of all the services Omar has received, or is it, I'm sure that every child is different and has different abilities. But I wanted to, let's see here, make sure I'm looking at the right information. Affects many systems, as Lisa pointed out, and many body parts. They tend to have a low birth weight. They do tend to have skull issues and spinal issues, and you may see them with spina bifida.
He has a huge scar up here, shape of a butterfly. Was open.
Yes.
Like
and their facial development is affected by the way their brain is developed. And you could see by the faces of those children that were in that article that Lisa shared that they all had a similarity. So, it was after I had seen the face of that first child, yes, I could look at Omar and say, yes, he looks similar. He just surprised me with how much more able he was. 80% of them have heart problems. Cleft lip and palate is common. So neural tube, are you seeing this, the cleft lip and palate and the spina bifida, the tube, epithelial tube and the neural tube are both affected. So I know that with spina bifida, it's the folic acid deficit that you see. So I wonder, if folic acid would have any effect on a child that already has the genetic propensity to it. That would be an interesting study. They tend to have low muscle tone, and that is certainly what I saw with Omar. So it was very interesting to me to hear that he's getting Botox.
Yes.
Because that is for very high tone. And sometimes you'll see mixed tone, obviously. And you did see him kind of, looking like he was using more extensor tone, like when he was walking, but that could partially have to do with the way he was being assisted. Hearing loss is very common. Visual impairments is very common. Obviously, the intellectual disabilities. The seizures are common. They have very slow growth and they have difficulty feeding and digesting their food. And there are a variety of support groups. There's one called SOFT, which is the support organization for trisomy 18 and 13. There's another group called Hope for Trisomy. And then another group called Unique, which deals with rare chromosomal disorders. And so that was the information that I had kind of gleaned to kind of just, reiterate the things that Lisa had already shared with us. So we kind of have a picture of what these kiddos look like. So of those of you who I can see, have any of you also seen a child with trisomy 13? No. Okay. All right. So again, not many of them out there, rare, not rare by how many
are born.
Are born, but rare for how many are going to be living long enough to be seeking therapy. All right. So then next, thinking about this child that we saw, okay, thinking about how many people here are speech and language? Okay, so we've got Andrea to help give us the speech. How many do we have our OT? Okay, and PT? All right, so maybe a few more PT, but pretty similar here, OT and PT. Thank you guys for coming on. It's great to see your faces. All right, so pick a okay, because I'm PT, I'm going to pick PT first. So from a PT perspective, and this doesn't mean OTs and speech language don't weigh in. So let me just say it this way, from a gross motor perspective, from a postural perspective, Joanne, what did you hear Lisa say about the way he sits that told you that when he got on the horse, he wasn't going to have good postural control?
Well, I wanted to comment the way he was sitting and using that speech device. He was just totally, for one thing, the seat depth was too deep. He didn't have any trunk support. His feet weren't supported on anything. I don't know if that was a video. I didn't catch it from school, but yeah, he should have had his feet supported. He should have had the correct depth to his seating. It would have made him have better stability for using that.
For using the device.
Yeah.
Yes.
I was going to ask you because in the beginning, before you said it's typically low tone, I was like, is he low tone or high tone? He has AFOs. It was, but yeah, he couldn't hold his trunk up when he was up there on the horse.
No, well, and he's come a long way. He can, but he needs to rest it and then put himself back up. But definitely. And then he likes to just move. He just really wants the input of movement too at the same time. So it's really hard.
Well, it's interesting that you say what you do about how he seeks out the music. The little girl who I watched the video of, they were basically saying, if you don't jostle her, she was, again, much more involved visually for sure and cognitively. If you don't jostle her or have a light or do something that stimulates her, she goes to sleep. And so I think it may be similar with Omar in that, he has more available to him, but he still is seeking that sensory input in order to just keep his brain aroused and to be able to be active. And so the thing that told me that he was going to struggle on the horse was the fact that you said he can now sit in a tailor sit position. So tailor sit or crisscross applesauce, the idea being very wide base of support. You can have very low tone, like really no control, and still sit upright because your base is holding you there. The question is can he move in and out of that sitting position?
He's crawling.
Is he able to get in and out and crawl?
Crawling that, yes, apparently. Well, I have not seen it because I keep asking Mom that they just got a new it's almost like a gait trainer for crawling. I don't know. I'm not a PT.
Okay,
so
yes,
I
yes,
don't know
yes,
what
I
it's
have seen
called.
this, yes, uh-huh.
But he can do it. He can move across the room that way. And so I wanted her to bring it. So maybe that would also be a motivator for, because he likes it. A
Okay,
motivator for him to
okay.
move
So
from
if he
sitting to
doesn't have that, Lisa, can
Mhm.
he commando crawl?
That I don't think so. I don't know. That's a good question.
Because you don't need to be, you
I
know, you
don't-
don't need to push upright. You can
No,
just,
he
you know,
does. He
literally
does
crawl.
commando crawl. He does commando crawl. Mom said he does commando crawl.
Okay, all right. So
Yeah.
he's everything that I'm hearing from the fact that they need to use the support system for him to creep or crawl, you know, that he sits in tailor sit.
Mhm.
What Joanne commented about the way he was sitting in his wheelchair, give him no, I mean, any of us give us no support and we're all kind of slouch. He's just a very slouchy kid with very low tone.
Mhm.
And so we see him kind of throwing himself forward or throwing himself backward. And it's
Mhm.
like he just doesn't have that postural control. And so when he tries to pull something in, it's that all or nothing effect. He either pulls in some flexors and boom, he comes forward. He pulls in some extensors and boom, he goes backward. And it seems like the horse has the potential to give this kiddo a lot with
Mhm.
regards to, you know, postural control.
Mhm.
So, okay, so we've gotten some ideas about PT. So from the PT perspective, if you were having to do an assessment on him because you were doing your evaluation, what assessment tools might you use? Anybody
Sure.
speak up. You don't have to raise your hand, Michelle, just speak
Oh.
up.
Probably the GMFM, gross motor
Good.
functional measure.
Yeah.
I do have a PT question.
Yeah.
I'm sort of curious. You were saying he has a thoracic support. Is it soft, hard,
It's hard.
She
stretchy,
said it was hard.
Hard.
hard, like really hard, firm? Was it
Yeah,
like black or
it's
navy?
hard. I mean, it's hard. This part on the outside stretchy, but there's something firm inside.
I'm
That was-
sort of curious, only because he also has an immune deficiency and didn't develop like responses to pneumonia vaccine, so they have him on sub-Q IG.
Right.
And with TLSOs, you have impaired thoracic expansion.
Okay.
And so sort of to me seems a little bit like a recipe for a disaster from a respiratory standpoint if he gets sick or anything, especially because kids with immune deficiencies, and I actually my daughter's actually on that same medication, that Hizentra sub-Q IG. So, and
Okay.
I naively thought that once you start treating immune deficiency, oh, they're normal, like their immune system. They're not. They're not. We found that out this winter. The immunologist looked at me point blank and was like, still not a normal immune system, still going to get sick more frequently, still going to have more trouble with illnesses. So it's sort of, I know that some people are doing TLSOs with cutouts and then abdominal binders on top in order to allow more gills on the sides, all different things to allow more expansion with breathing while still providing three-dimensional support and stability.
Not that we're here to support any particular company, but Sure Steps seems to have a nice TLSO. Have you experienced that? You kind of,
Oh, but
I'm going to tell you
I'm
from your
looking.
face, do you have experience with that, Michelle?
I've seen them. I don't have anyone using them right now, but I have seen them and heard of them. But you're saying he only wears it when he's riding, when he's on the
Yeah.
horse?
Yes.
Oh,
Well,
it says-
so that was when, yes, he's only worn it when he's riding. And I was curious if, that's my question, is the hard shell
No, I would say we are not wanting to encourage that.
good? Because that's what I'm
Because you're
wondering. I
just
asked
providing
Mom.
him an external support and therefore he's not going to gain any active control.
Exactly. So I wondered, but because I did suggest to Mom that I'd like to try it without it and just use a gait belt.
Yeah, well, we'll talk, we'll
Well,
get there
later
and we'll
on.
talk about equipment,
Okay, perfect.
for sure.
Good.
We definitely want to do that.
Okay.
Okay, OTs. What
Can I
did you
jump
guys,
in real
oh,
quick?
sorry, Lisa.
One more PT comment. You were asking about like assessments, and I like the idea of the GMFM for like the overall function. but I was also thinking of the Satco because if he tracks well enough for that, because that way you'll be able to, if you're not familiar with it, it goes kind of by level down the spine. So you could give him a lot of support up like under his armpits and see if he can manage head control and see if he can track something back and forth. And then you drop down a level and there's like a way to document. I'm pretty sure it's free and you can just look at it online, but that might give you a really good objective way to see if you're making any progress in his trunk. If that's one of your speech goals, which might not be, but that's what I would do as a PT.
Absolutely.
Yeah.
That's awesome, Lisa. And that SATCO stands for Segmental Assessment of Trunk Control.
Okay.
And yes, in fact, if any of you want to email me at hippopt@aol.com, either tonight or tomorrow, I can send you some information on that. I just sent it out to the folks who are going to be taking the part 2. So I do have information on it. So thanks, Lisa. That crossed my mind as I was looking at him, and then, got off on a different tangent. So excellent to point that out. Thank you. All right. OTs. What did you guys see from the OT perspective?
Would it be wrong to put a wedge for sitting to get his pelvis in neutral?
It definitely would not be wrong, but are you thinking just sitting in general or specific somewhere?
I was just thinking during the session.
Okay. All right. So yeah, so we aren't on the horse yet. So that's why I kind of, was generalizing, because it could be beneficial anywhere, including in his tailor sit position, to just help him get that concept of getting in towards a neutral or even towards an anterior pelvic tilt, because this boy is basically living in a posterior pelvic tilt. So yeah, great. OT from the perspective of his ADLs, we didn't hear anything from Lisa about that, but I'm going to guess he's probably not doing too much with regards to that. So Lisa, do you have any idea? Does he help at all with doffing his clothing? Does he try to take off a shirt or a pair of pants or anything like that? We did see him holding up that little thing that holds the food that kind of allows him to eat a bit of like pureed type of food. We saw him reaching, and it was interesting because when I saw him reaching for the Dynavox, initially his elbow was like stabilized by the armrest, but then because I was looking at the height of that Dynavox, to me it seemed very high, but he at least was able to actively reach up, so he was able to lift his arm against gravity, which was a good thing to know. I think if we get him in a better position, as Joanne was pointing out, he'd have even better reaching ability. So I know that from the OT's perspective, you didn't see a whole lot, but just what you do know about him, what kind of assessment tools might you want to be using, or what do you want to know?
He does have limited. Sorry,
What's
I
that?
forgot to mention that his left, he has a limited range of motion on the left shoulder, left side. So his right hand is the one that he reaches with mostly.
So he has limitations skeletally?
And somehow in his shoulder, yes. This arm can only go so high.
Okay.
And I don't want to overextend it because I guess it's limited
Yeah.
there.
And you're not an OT or a PT, so you
No.
got to be careful to, yeah.
Yeah.
All right, OTs, what do you want to know more about? What kind of tool might you use for assessment?
So I'm not certain on the tool for assessment, but my overall thought as an OT with this kiddo was just positioning. And I think just to echo on Joanne, just a lot of positioning. So if his vision is limited, he only has that right eye, his ability to functionally access anything, like the Dynavox or any tool that you're going to use with him is limited. So positioning him in such a way that his right eye has that advantage to actually
Mhm.
access and see what you want him to. And when he was sitting in that chair, agreed it's the wrong chair to sit in. But some more support if he is going to be upright against gravity. But my other thought was, what if to increase accuracy to start, what if you had him maybe in gravity eliminated, like sideline on his potentially left side, so his right eye and right arm are free to see and access. If he can, I don't know if that might make sense, but even just looking at accessing that device from a less challenging position for him to
Mhm.
start, and then work up to maybe sitting and I don't know, I could be off with
Okay.
that, but for me, I just saw a lot of positioning where we
Yeah.
could help him out just to start.
Okay. Okay. So Kristen, you've kind of touched on the fact that while you didn't have a particular assessment to pull out, the idea is you're looking at his impairments. So we're getting down into the impairment level and you're looking at, okay, what positions could we put him in where he can be more functional? So that actually could be an assessment, of doing exactly what you just suggested and then seeing how he does as compared with sitting, a supported sitting.
Sure.
Marty?
Oh, okay. Sorry about that. He's really not a child that I would do like a standardized assessment. So I would think more clinical observation, and talking to the parents and getting medical history and those kinds of things would be part of my assessment. You could do something like a sensory processing measure or something that's more of an interview with the parent to get kind of a background in terms of which sensory systems might be stronger for him to learn, or which kind of where he's at sensory wise. So those would be the things I
Thank you,
would
Marty.
think.
That's exactly where I was hoping somebody would go. So great. Thank you very much. That's perfect. Yeah. So we do need to know what this child's sensory processing abilities are. What is he seeking? What we know auditorily, that's
Mhm.
like his thing, but auditorily in conjunction with, we don't even know like what his vestibular system, like his apparatus, what's intact, what his vestibular system really is. But obviously, that would be worthy to see, how he reacts to vestibular stimulation as well as the probe. So yeah, and I like the concept, Marty, of what you were saying with the basically a parent questionnaire. That's going to be a good way of getting that assessment. Anybody else have any?
Yeah, how about also the WeFM, just to get some data about self-care? Of course, we could do a more thorough parent report, qualitative interview, but just for a nice, measurable chart, would you guys see the WeFM being beneficial for showcasing self-care in the initial evaluation?
Yeah, I do. And I think again, what we're trying to throw out right now are all the different options of what would be a possibility. And then, what it's really going to narrow down to is what's the family's focus? What are they wanting us to work on from the therapy perspective? But the more information we can gather, the more we can be proposing to the family of the things that we could be working on. So I like that idea, Amy. Thank you.
Yeah, and it's also a parent report, so it's something that the parent could fill out at home or online, or with the therapist during the evaluation. And it's free.
Yes, we do love that. All right. Any other OT perspective, level of, impairment that we'd be looking at? Nobody's really talked about range of motion other than what Lisa had mentioned with regards to the shoulder, but I think range of motion Yes, Marty?
I was thinking, I suspect, I mean, you would want to look at his fine motor and his hand skills and stuff. It looks like he has a swiping, kind of more of a swiping motion, as opposed to, and maybe a gross palmar grasp that he, although, because I think he was holding on to some kind of a chewy toy or something. So we can assume probably that he has a gross grasp. And then it would just be a matter of, again, a clinical observation where you're setting up something that is highly favorable, that maybe is familiar to see. Can he grab? And then how does his hand function and how far can he reach? And can he go reach to the side or in front of him? Or, then I think it's really important to look while, the eye-hand coordination isn't there because of the visual impairment. And so looking at how you're positioning whatever you want him to grasp to make sure that it's within his visual area, that so he knows what he's looking at to see if he wants it or not, So, but I think that's more. And then the other thing you could also kind of relate to that is doing a visual efficiency screen, which is, seeing, does he have visual tracking? Does he, go from near to far, or, whatever kind of where that is, because I think that's those two combination is really important to get the picture of that eye-hand component.
Okay. Sarah's saying it seems like a simple switch for
good.
music might be the first step to see if he can use a button. I think she probably said effectively. They were asking him to touch a button and then to sign more, which
He can
seemed
touch the button,
pretty
but he
high.
can sign more. He has signed more. He has used it. He has signed more, and he's also tells the horse to walk on by tapping twice.
Okay.
So,
But he
gotten that.
says more, which is a two-handed.
Yeah,
You're not a speech
Right.
therapist, thanks, Sarah.
I know.
So he is using his left arm. He's just not reaching up
He
as
just can't.
high.
He
And
can't
yet, from
lift
what
it.
Marty was just saying, good point. Does he not use his left side because he doesn't see his left? His left visual field is impaired. So,
No, it's a-
are the two even connected? Another impairment that I really would want to address is his tone. And I would want to be doing like a modified Ashworth on the extremities to see, really what we're dealing with tone wise. And then obviously, again, from, I think it was Kristen, was just talking about observation, but just observation on positioning and activity level and how the tone changes and alters with positions and activity. Any other PT or OT assessment types of things you'd want to be looking at before we move on to speech? Okay, and it's not like we can't come back and talk about anything. All right, Andrea, you're going to be on because I think you're the only other speech person here. So I'm going to be asking you since Lisa's already. Oh, Kathy, good. We have two speech. So what kind of assessments would you be doing on Omar?
Well, Toby has an amazing set of resources for full assessment. So I would start there. Their reps have been so great with us and with our kids. And I'm super interested to see if his right eye vision might be enough to be able to help him access an eye gaze device.
It wasn't. He was evaluated for that, assessed for that, and he did not have. No. I guess not.
Was not evaluated,
He
or
didn't have
he
enough eye gaze or something. It didn't enough tracking to do it.
Oh, well, that's a bummer.
I
Then
know. Would
right,
be.
the ideal. Then a go talk, and probably parent assessment. I would probably start with a communication matrix, just to see where his communication intent is. And speaking of free, love that about it. Mhm.
Yeah.
So I know Brianne has a comment because she has a son who uses an augmentative communication device. So Brianne, go.
I would say I am not a speech therapist. The experience I have is with my son only. So he was just evaluated by Tony Dynavox, and we are actually working on getting a trial for eye gaze, but he has CBI, which is completely different than what this child has. And he's had an AAC for 7 years, and it may be an option for this child. My son also uses a lot of the swipe. He does not have any pointing or fine motor skills. He's also super motivated by music. So I'm wondering, so my son uses, it's called an Accent 1000, and he uses an audio only.
All right, guys, I'm gonna mute.
I'm sorry, what was that? It's a core scanner is what he uses. So he uses an Accent 1000 with a core scanner, and he uses a switch. So he uses a switch to activate, and it scans all the words. And once he hears the word in his little microphone in his ear that he wants, he hits his button again, and the talker talks.
That sounds great.
So if you guys have some extra time, I have it in his room so I can show it to you and how it works. But that might be an option too. It's very simplified. The only difficult thing with it is it took a long time for my son to learn and memorize where all those words were. So it's not very sensical. So when you open more, there's more words underneath it, but it doesn't necessarily relate to more. Like some of these are really kind of where they place some of these words were not super logical. And you can't move them because they're all layered. So you can start with 8 words, more, go, play, stop, some basic stuff. And then my son's up to 125.
Oh gosh, good.
But once you get to some of those words, they're now in folders. So you have to open one word to get to that folder, and then you have to open that folder to get to. So it's a complicated system, but you can simplify it to 8 words at least to say more, play. But I don't know if there's any other systems that maybe are more audio based like this one. This is 7 years old. This is the only one he's used. I don't know what's out there, but just using a simple switch to communicate may be easier. And instead of just having a yes or no option, or, something that gives him a little bit more. Because do you know where his cognitive status as far as receptive or?
It's pretty low. I mean, that's why I said it would be best if he did more low tech, at least for home. It's more portable for one, whatever he's going to do, even if he has a switch. I've been working on him with a switch, a button, a Big Mac. Yeah.
Lisa, with the grasp that he has, is he able to access Velcro for like a PEX, a super low tech?
No, I don't think so. I don't know. I don't think he could do it. He has cataracts on top of whatever he has with his vision in his right eye. I really don't know I don't know how they're even measuring really what his vision really truly is. I know they say he's nearsighted and he has vision out of his right eye, but I kind of wonder because he doesn't ever focus or track really. Other than he knows where the screen is and he can do this, and he knows that something will come out, he'll hear it, but I don't think he even associates it. Mom claims he does, but I have not observed it.
Because
Marty, Marty, go ahead. I know you had your hand up, and also you were the one who was, I think you were the one that was suggesting the vision assessment.
Yes. I would think it would be really important to assess that cognitive. I mean, we didn't talk about that, but I mean, kind of the first level, it looks like to me, he has cause and effect, so that he knows that if he signs more, he gets something. There's some kind of an effect. And so if that's the case, then I think, does he make choices like the next level? Does he have, can he make a choice between, 2 things? Can he anticipate, if I do this, will this happen? Or can I initiate, if I cry, am I going to get something? Or, those, and to really kind of look at that cognitive piece, because obviously I think then you can put visual things in front of him that he can see it, or if he can't see it, even feel it, so that he could make a choice, even if there was something like tactile that he liked, or even making a choice between his music if he loves his music. And maybe he has to tap, tap the switch, to get a certain type of music, or to turn it off, or, or whatever. I don't know. There's lots of things that you
Been
could set.
turning it
I
off,
think
and
it's-
then he's having to activate it to get it turned on. That much he's can do, but yes, you're right. It's that's exactly
I
right.
think that's part of the evaluation process. I think that would be really important, because that's how you're going to communicate, with him.
Right.
Yeah.
He does have preferences with songs, and he does express that by whining to, like, his mom knows when he doesn't like a song. He's down to only like 2 or 3 songs that he only likes. So it's kind of interesting. Like, if she puts a song on, he's not gonna like it. He'll let her know, and she has to change it. It's kind of cool.
Joanne.
Because he's technically, well, he's got a visual impairment. Have you been able to access his IEP from school? Because if he's been evaluated by the vision people in the school district, you might be able to get a really good report, or maybe mom has one, to find out exactly what his vision is. And sometimes with those vision kids, or, you were saying the music, we used to have a song card, and each song had a specific picture on a card, so that instead of him whining, he could pick the picture of the song that he wanted. We used to do that with some of our kids. So you would have a picture
Yeah.
for that song.
Would, but I don't think he can discern.
You don't think he could learn that?
visually.
Or visually, well. but
Does he
said
discern color,
Discern
Lisa? Could they be
Yeah.
different color cards?
visually. He's not able to identify it.
Not
I mean,
identify it.
Not identify it. He's
He
not
doesn't
able
need to label
discern
it. It's
No,
just,
no. I mean, I don't think
discern.
I haven't observed it yet. Let's put it that way.
We used that with pretty low kids. A certain picture meant a certain song. And it might be, if he's really low, it might be a real picture instead of a drawing. Because they respond to that first versus the
right.
drawing. So the real picture of something with that song. But yeah, I mean, if you had a better vision eval, even if mom could provide that for you, because I'm sure he's been followed by vision, or in the schools by vision. I mean, maybe he has, who knows? I mean, he might not be. With all the brain disorders, he could have some cortical visual impairment also, where he's not really interpreting what he's seeing. But I think that would help you in knowing where to go.
Yes.
Hold on just a second, Andrea. Kathy, did you have something to add?
I did. I was wondering, yeah, I didn't know if I unmuted. I was wondering if he has only been evaluated through Toby, or if he has been for a full augmentative workup.
It's only been through the Toby so far. And so, from what I understand, what mom said.
So each state has it's a government site that you can go to, and they provide resources on augmentative, and they will loan out devices. I assume they're all similar. The one in North Carolina is phenomenal, and you can get all kinds of help for augmentative, and they will refer to people in your area who are specialists in augmentative, and they do full workups. And the ones that I've had success with have looked at the vision, and they look at the positioning, and they've talked about the color things that you were mentioning, stuff that it's not my specialty. I can follow through on stuff, but I need a place to go. And so I use that resource a lot. So I would maybe look into that.
That would be great. I've reached out to people that I used to work with who's an AT person. I was asking them to come out and maybe do an assessment actually at the facility.
There are specialists, and I have found it's very different than, I've had good luck with the reps from Toby, but I've had a much broader resource base when I have gone through other avenues.
Right. I want to know options other than Toby, to be honest, but I don't know. And then the school also, we just requested that they do another AT eval. So we'll see what they come up with as well. And mom does have a vision. I know she got a vision report to answer your question as well, that she can provide me, that was done at a ophthalmologist or whatever you call them. I can't even think now at this point. I'm like, yes, she had that done as well.
In
The
ophthalmology?
school report, yes. Now the school report, it's a district that I am not familiar with, but they seem to do things a little differently than we did in our school district. So they only providing services that the teacher can, they pretty much said he doesn't need any services, the teacher can provide them all, so he didn't get OT or speech at school, through school. I don't know, ours would have had the speech and the OT involved and done it collaboratively with the teacher. And it wasn't provided that way at their school. So mom was upset. She was a little upset. But anyway, they're fixing it now.
Okay. Well, Kathy, thanks for that information, because it does seem like the Toby's like the Cadillac of augmentative communication, and it's like this child's just like not even ready for the Volkswagen, and there's lots of other options here that should be being looked at, rather than something as A, very expensive, and B, just way too technically advanced for this child at this time. So yeah,
There's lots of other options out there.
Yeah. All right. So this has been awesome. So let's go ahead and step into the treatment, envisioning that we've all done these assessments and we have a little better information with regards to him. We already know that he's receiving conventional or traditional or clinical PT, OT, and speech, that he's getting some aquatic therapy. Do we know is there a specific discipline that's providing that aquatic therapy, or is it more like adaptive aquatics?
I'm not aware of it, actually. I just learned of that today when I saw the PowerPoints. So he did not mention it before. So
because obviously I love aquatics, and I think that would be a phenomenal tool for him. But then let's just go ahead and step right into, okay, let's see here from Andrea, at least. Okay, hold on. I've gotten a couple of okay. Okay, Andrea, you're saying you'll send some pics of some very low-tech communication options that you've used with your severely visually impaired kiddos. So that's perfect. That's awesome. Thank you for sharing. Whoops. I need to get rid of this chat box. All right, so let's move on to, we're going to all envision that we are, as individual therapists, PT, OT, and speech, are going to be working with Omar, and that we've decided, well, first of all, what are we going to think about? What are the precautions going to be for him with regards to the selection of hippotherapy as a treatment tool? Are there any precautions that you all have seen or have? Michelle?
Was there something about bone density?
Yes, I was just
On that
remembering the
slide?
same thing. Yes, ma'am. Thank you. So low bone density. So we'd want to be finding out a little bit more about that. I mean, he's 8 now, so, it's not like he's 4 or, more cartilaginous. So we would be wanting just to have that checked out and confirm that hippotherapy and being on an elevated surface with a risk for a fall is going to not seriously injure him. Andrea, did you?
I was waving goodbye to my husband, but I sorry guys, I'm still at the farm and all things are still happening here. But I did have seizures, but his last one was 2022, so it's not active seizures.
Yeah, and she had said febrile seizures. So, you know, obviously if he's febrile, then he would probably not be indicated for coming out anyway. All right, anything else?
I think there was something with his head, right? I would say, was part of his skull open, and is that fully healed, closed?
Yeah, what's going
It's
what's
fully
going on there?
closed. And he had a like a custom made helmet they got for him for that. But it's fully closed. He's had several surgeries. It's fully healed and closed.
Okay.
There's just no hair there.
Oh, okay. Where did they get the custom made helmet?
Good question. I don't know.
Is it certified?
Yeah, no, yes, it's certified. Don't get me wrong. No, it's certified. The
ASTM
Path
SCI
Center-
certified?
Yeah, the Path Center. This is prior to me coming there. The Path Center. They did it. They got it all approved through the Path Center when he
Oh,
started.
nice.
Okay. And
So
does
maybe
everybody
he's different,
remember?
and maybe it's a different. Maybe he's a. Or if he got one that fits better now, I'm not sure if it's a different one, but that's what she mentioned in the beginning.
If you happen to learn, Lisa, where they had that made and like how custom it was, that would be a lovely thing to share on the therapist Facebook
Okay.
group page, because I think a lot of people would love to know where you go to get a custom helmet.
Let me ask. I'm writing it down so I can ask. Okay. Got
But
it.
just keep in mind, you know, the differences between how we handle a session if we're not using an ASTM SCI approved helmet is that you need to have a waiver signed, and the family needs to be aware that you're using a helmet that's not been approved for equestrian activities. And then you have to, by path standards, and we all should be following these, is that you need to make sure that you're going to have a horse leader and a person on either side, which I can't fathom with a child of this involvement that you're not going to be doing that. But those are, you know, those are the things we need to take into consideration for choosing to use something that's not ASTM SCI.
And I think also in a closed arena, not
Thank
out
you.
on trails.
You're right, Michelle. Thanks.
I have 2 kids not using standard, you know, ASTM SCI riding helmets. So I helped make sure that those waivers included all those pieces.
Perfect. Thank you. Okay, so we've got a helmet that's going to adapt to his head. We're going to check and make sure that his bone density is sufficient. What's the next piece? And we need to make sure we have a team, right? We need to make sure that we have a horse that's going to be appropriate for him, but that we also have the horse handler, and we also have a sidewalker that's going to be able to assist. So we're looking in our barn for the horse that we think is going to be most appropriate. So I'm still a little iffy on his tone. I don't know if he's high tone or low tone or fluctuating tone. He's 8. He doesn't look very big. And my personal question would be, how much hip abduction does he have? How much can he spread his legs? So that we can determine the width of the horse that we're going to select. I think, you know, what do you all think about height? You know, I'm sure we're all in agreement that we're not going to be picking a 16-hand horse for many reasons. You know, one being we don't want him so high from the ground that he becomes anxious, but we have to be in a position with him that we can handle him because he's going to need a lot of support. But when it comes to width, what I think was interesting, Lisa, is that you said he seemed to like your place or do better at your place versus the other. And you showed us the fjord, and I happen to be very fond of fjords. And I do love oftentimes their wide base of support. And I would think if he has an adequate range, that a wide base of support may be appropriate for him. But if he doesn't have a wide range, or if he has a tiny pelvis, then that fjord may be too much, too wide, and that's going to create more problems.
Yes.
So you have some assessing to do to determine, which width you would want to use, because then you're going to add padding or something else that's going to be making it even wider. So anybody have anything they want to throw out there with regards to height or width of a horse? Yeah, Andrea?
To ask a question, it looked like that fjord was on a more narrow, more petite fjord. In the pictures, in the videos. And did you say that you had less padding on that horse than you had nicer padding, thicker padding on your horse? Or
Oh,
it's actually
no, I had made a roll of pads for him to use as a support in the front, but the pad he sat on was the same, basically.
the same pad?
The fjord, she's not, I wouldn't say she's a narrow or petite, but she's not, you're right, she's not like a huge, she's not as wide as some that it could be wider, but there is another pony there that is narrower, which I use for the child with CP. And I would like to try him on her. But their concern is all his movement. So I'm wondering if there's a way to help stabilize him a little bit more so I could put him on that horse. That's really like with the wedge, or like someone was mentioning earlier, etc., to get in that right pelvic position. Because I figure if he's narrower, it would help him get in a better position as well. Or am I off?
Like that.
Or am I way off?
What's that, Brianne?
What about a hippo helper?
Yeah, you're getting ahead of us. So just hold for a second, okay? Yes, you're going in the right direction for sure. But we're still focusing on the horse before we're getting into the equipment. Okay, so let's talk first about the horse and get this figured out before we move on to the equipment, and that will be, then we have to think about how we're going to get them on and off, and then so we have a number of things to be thinking about. So
you had said he did better at your barn. The horse that you were using at your own barn, what was the horse narrower, and what was the movement compared to this horse?
Well, the movement, they're both big. My horse at my barn is very lateral movement. I believe the fjord is as well, but he's a little bit narrower towards the front than the fjord, but he's not like petite either. I just feel like his movement maybe is a little more it just felt a little bit more, I don't know, just felt smoother and more rhythmic, I guess I would say. I don't know why, but
How much does he weigh?
it went very well the way he at this point, maybe 40 pounds. I don't know at this point. I'll have to ask mom again. He's little bitty.
he's 45 pounds.
Oh,
I think he's around 40, 35, 40.
So he's tiny.
Yeah, he's not big, but he's strong. Yeah.
Joanne?
The one thing that I noticed on the first video, and that was not on your horse, was it? No, was that, he had his trunk support on. He was upright. He wasn't leaning back, but his hips and knees were very flexed.
Yes.
And I'm thinking, I've seen that in kids that are too tight, and they flex them, and because they can't get around the horse. And I didn't catch that on the other one. That maybe have been the difference, that the other horse was thinner, because typically if they are, adductors are really tight, they stay in hip and knee flexion, and he was very flexed.
Okay, that's
He was,
my,
he was actually though flexed on Lisa's horse as well.
He was.
So
I
you know,
remember.
the thing you want to be very careful of, Lisa, is that you want to make sure that when he's sitting on the horse, ideally his hip angle should be 120 degrees. Okay, so if you think about a chair being 90,
right.
his hip angle should be more like 120. But the important thing, and the thing I didn't see on either horse with him, is his lower leg should be perpendicular to the ground.
It's not.
That's going to feed his pelvis. Okay, where his leg is very influential to what's happening above. So you want that hip angle at 120, and then you want that lower leg perpendicular to the ground, not pulling back. And that was what I saw, was that it was tending to pull back.
Okay.
When you take his
Andrea?
trunk support off, he's probably gonna be a lot more posterior if he's really low
Even
tone in his trunk.
more.
So you're gonna have to do a lot of handling, physical handling to help him maintain
You
that.
you are, yeah. So let's first just get into, you know, the shape of the horse and you know, then we're going to move into some equipment, and then we'll get into the handling. So Andrea?
And not to jump too far forward with this, but, and this would be where I would phone my PT friend next door. Would we want to consider a broader horse that perhaps the child could get and tailor sit?
Mhm.
But I think for sure.
So
from-
I'm going to, yeah,
I-
my inclination as a PT is going to say, I would like to see him out of tailor sit. He's
Okay.
using tailor sit, and he's not having to be active in that trunk. And our whole goal on the horse is to be active. So let's open those hip angles, but let's give him the base of support different than the tailor sit.
Gotcha.
So, and kind of middle of the road between the two, Andrea, could be like the side sit position.
That was my guess.
And so that's like one leg's in tailor sit and the other leg is in the more traditional position. And so that might be your compromise.
And I think about that from the speechy selfish perspective. If we're using an AAC, how can we then facilitate?
Gotcha. Yeah.
Yeah. We can get a kid in that position, and then we're going to get that upright trunk support, and we're
Gotcha.
moving AACs there, but also side, and then put the AAC on the hind end. So, but
Yeah. And to me, the use of an AAC on the horse seems so far in the future. You know, let's first of all, let's just get him accommodating to the movement and giving us some good or some improved postural control before we overlay with the AAC. But I see where you're coming from. And so, yeah, I think from the perspective of if he was ready to use an AAC, something like the modified side sit could be good. All right. So what you need to play with, Lisa, is first of all the shape and size of the horse, and find the right size that allows his hips to be open, you know, to have that open hip angle, and the lower leg be down. And that should allow his pelvis to be in a neutral position. If he's way back, that's telling you most likely it's too wide of a horse.
Yeah.
Okay. And then if it's too narrow, he's just going to be very unstable. And you're going to be able to tell that pretty readily that he's not getting enough support if it's too narrow.
Okay. I am gonna the horse because I think it would be.
And then the movement that you're looking for, you were talking about the lateral, how both of those horses tended to be more lateral. Does anybody else here have a feeling of what movement they would like to see the horse have as a primary for him? Joanne?
Well, looking developmentally, you get anterior posterior flexion extension before you get lateral.
Yep.
So if he doesn't have the flexion extension control,
Yeah.
he's not going to have the lateral. So you're
Right.
for the rotation, because that's way down the line. So
Right.
I want something with a little more gentle forward back or flexion extension.
Yeah, exactly. Yeah.
That's
So
great.
yeah, so we need to give this kid control in this plane. Okay. And like Joanne pointed out, sagittal plane is the first plane of movement that we gain control in. If we think about babies, you know, they're lying on their backs, they're starting to bring their hands together, they're starting to reach for toys, they're starting to lift up a little bit, they're working their flexors, they're pulling their legs up, they're working their lower abdominals, put them on their tummy, they're pushing up, they're working those neck extensors, those back extensors. The more they push up, the further down the back, they're developing those extensors. So because he's not doing probably either of those, you know, he has very limited trunk control. So we can give it to him when he's on the horse.
Okay.
So I'm going to jump ahead for a second just to kind of take it that next step and say, if you've got a horse that's giving you more anterior posterior, you're going to want to be working in long straight lines with this kiddo. He doesn't need a lot of directional changes. You don't want to be working circles. You don't want to work in a small arena. If you've got the ability to be on a long lane, you know, or someplace where he can just go in a straight line, that's going to be your best bet to start to give him more of that flexion and extension.
That's all we've been doing, really. Walking.
Okay.
Straight. Actually, that might be part of the reason at my barn. It's like we can go long,
Good.
straight
Awesome. Yeah.
Walks.
I've been
and
to a
just-
couple of facilities where they literally, their arena was round. It's like,
Oh,
this this is limiting what you can do. All right. So I know that Brienne was talking about a piece of equipment. So now we're going to go back to you, Brienne, because now's the time to talk about that.
Well, when I went to the part 2 course, they had an amazing little thing, and you can probably make something similar homemade as well. I'm sure OT could probably whip up something really nice. But it's something called a hippo helper. And I think Shining Hope Farm sells them. And it's I'd have to go out to the barn to get it, which is all the way out there. But it's basically almost like two pillows, or like your breast friend or your boppy pillows type idea. But they're velcroed onto each other. So you can
I
have
have it already.
Yeah, and you can velcro it around.
Tried it.
Yeah. So that way he doesn't like it. Is that what it is?
It
What are
didn't
you
work
saying?
well. I did try. I have it. I use that. I just got it from the conference, and I've been trying it with him.
It helps with that real slouch kind of like
Yeah.
posture. So that way when he does kind of lose that posture forward, he's got that support upright, and then hoping to kind of get that extension a little back, but that graded extension versus the throwing yourself back extension, because that way he has a little bit of support.
So that video I showed you was just in the beginning where I was trying to show what he would be like. Basically, as much the minimal support we would give, right? But I, realized that's not appropriate. So I got those pads. Like I said, I rolled them up at my barn when he came out for a visit, and it did help because it gave him enough support he could lean and then sort of lift himself up. Now with the hippo helper, he just leans into it. Like he seems to lean into any pressure. So he's going to lean in. I don't know if he's sensory seeking, right? So it's almost like the hippo helper makes things worse. Which I was shocked by, because I thought, oh, this is going to be great for Omar. And so I'm still at that challenge now of equipment. And then someone else did mention a wedge, which I was wanting to know if we could go into that too as well.
So first of all, interesting that you would say he leans into it. That is like in my mind and with my experience, the kiddos who just sink into whatever support is given, they tend to be the low tone kids. Okay. So you're kind of, I feel like we're gathering information here about, he is a generally low tone kid. The thing you need to be a little careful about with using a wedge, especially on the horse, the wedge is going to go under his ischial tuberosities. It can literally be a folded hand towel that's underneath the saddle pad that's sitting under his ischial tuberosities, or you can use a little wedge. But the idea is that it's going to lean him forward. So he needs to have the ability to extend his trunk to counter that forward shift. And so you do need to give him some kind of support. Now, with the pads that you had in front of him, was he weight bearing on them? Was he like pushing into them with his hands? Or what, how were you using them and
Yes. And he would, yes, he was weight bearing on them.
he was weight bearing on them. So he can weight bear with an open hand, fisted hand. What's he using?
He uses a fisted mainly.
Okay.
He can do both, I think. He does this, he can do this if he's, but then he'll hyperextend and then he'll go in and then he comes back. So he's pushing, it's like
Okay,
thrusting.
so are you back behind him,
himself.
kind of helping to stop
Yes.
that hyperextension?
Yes.
Okay.
What?
So when he's on the horse and you've got this padding in front of him, how far away is it from his trunk?
It's right here. Well, are we talking about the hippo helper? The hippo
No, I'm
helper?
talking about whatever you found worked
The
better
one
than the
that
hippo
worked.
helper.
Okay, so that was lower than the hippo helper and it was a little bit more forward. It was right near, I'm not very good at describing this. I'd have to look at the picture again just to show you, but because he
Can
was
you move
sitting,
your screen and just show it with
he
you?
was sitting in that chair sit position. Yes, let me see if I can find it again. Okay. Oh. I have to remember how we did this.
No, just show it on you. Just
on me.
your own
I see what you mean.
screen and show it on you where it was. Just let us see you. Like if I did this, I could say, oh, okay,
So if he's
here
on
he
the
is,
horse.
and here's where the pad
He's
is.
on the horse. The pad would be about right here, and but it would be chest level. You know what I mean? Like if he would hit it, it was like he could lean into it or across his chest. Let's put it that way.
It was chest level. Okay, so show us how his arms looked when he was on there.
Here, go like this. So he would go like this, and then sometimes he would go like on his forearm, and then he would go like this, but he would also then thrust himself back. Sometimes he would sit up and then hold it, and then other times he would ride like this. Like he wanted to ride like that.
We don't want, well, ideally we don't want that for
No.
a very long period of time. Have you tried boppy pillows?
Yes.
And how did those work?
It's about the same. I mean, I have the boppy pillows. I have a boppy pillow that goes around him plus the hippo helper, and that's a little bit better because he's not going as far either direction, when he tries to throw himself. But I'm just trying to figure out if I'm even doing anything remotely close to what needs to be done to help him be upright.
Well, this is what we're trying to help you problem solve, because that is what he needs. He needs the assistance to be getting into a neutral alignment. Multiple boppies are fantastic. Honestly, I've used up to 3, 2 in the front and 1 around the back. And so, it's like a matter of him finding his control. But if you give him a range that he can work into, at least if he's moving forward and back, you're creating a parameter in front and back, so he can only go so far or go so far, whether it's your manual, assistance, or whether it's using these pads. The other thing you could use is if you have it a 2-handled surcingle. If he's fisting and he's holding on to something, he may be the kiddo that to have the firm support may work well for him.
Okay. I just got one of those at this conference too, because right now it's the single bar surcingle, and sometimes he does grab it. Momentarily and seek into the cushions. I do have a boppy. I mean, as you say, I use the boppy that goes around behind him, and then I use the hippo helper in the front. But maybe I need to add another boppy. in the
Mhm.
back.
Yeah.
So that,
I
Yeah.
was about to say, maybe with, it sounds like he's having trouble grading the movement.
Mhm. Yeah.
And problem is,
yes,
the
there you
more
go.
forward he's allowed to get, so the closer to the horse he's getting, the more
Right.
he's able to just thrust back.
Thrust it back,
Because
yeah.
he's trying to get up there, but then he just can't
Mhm.
stop once he's here. So he's just
Right.
going back. So it sounds counterintuitive, but maybe piling up the support so that he can only kind of, be up here. And then he can throw himself back, but it's a lot harder to throw yourself back from, your arms up here and
You're up
supported on
here.
something versus,
trying
if
to
you're
get his
down here. Yeah.
I'm trying because I'm trying to keep his arms in so that he's more controlled, if that makes any sense. Get his elbows either here over or in, so that he's
As
easier
opposed to, as opposed to
balance
what?
himself, as opposed to his arms out. Then when they're out to the side, because once they're out to the side, he's all over the place. Yeah. Is
Yeah.
that-
So kind of maybe almost a forearm support, like a, I don't know if you're
Okay.
kind of more of a something here
Mhm.
level. So that way it's harder to thrust back and really lose that. And that might
Okay.
take your time supporting that extension.
Yeah, it's
Like,
tiring.
not killing yourself.
It's tiring. Even with the bobby, I'm like, oh my goodness, this isn't working. This is so hard. Okay, this is great suggestions. And I'm
Yeah, I
also
like
gonna-
to do I do a lot of that also, like in Fran, you'll probably get to see some of that this week. Where try to get the kids that they're propped on elbows.
Mhm.
Because again, like Joanna was saying, like that developmental progression. This is a kid who did not probably prop well on elbows and then
Mhm.
get to he probably sort of skipped that piece. And so, and yeah, and then you see the kids, they're here, and then they they start pushing, and it's like, oh, and we all get excited, if they stop in the middle,
Right.
so that he recognizes,
Oh, you
oh,
get
that's where you wanted me to stop.
So
Can
help me
anybody
get-
think of an alternative position? It's not really truly alternative, but another position besides forward facing that might be beneficial for that upper extremity weight bearing?
I
Yeah, I
put
was
him
thinking
backward,
sitting
facing
backwards, yeah.
backwards.
Yeah, so rear facing, you could put him in that modified prone on elbows position. So the thing you have to just be really cautious about is if you turn him rear facing, that,
Yes.
you got to know the width and see how his hips are accommodating to the width. And again, he's going to tend to swing his legs back, which is just going to throw him even more forward.
Yes.
But if you can get him into, he's probably not going to have a perpendicular lower leg in that position, but towards perpendicular, but getting into, a weight bearing position that way would be another option. And you can use a boppy, or padding or something else if you wanted to, but it would just be another option for giving him some upper extremity weight bearing and starting to get him some proximal upper trunk control.
Okay.
And Joanne?
And this is just a suggestion prior to getting on the horse. All of those low tone kids really need some prep work before you get them on. And I get them on a ball and give them some of that proprioception and give them some of that feedback to get their trunk co-contractions, to get it started so that, in a more controlled situation than on top of the horse. Just give them that little preparatory work of bouncing and, to increase that awareness and the core stability before they get on the horse. And that seems to work pretty well because you can do some flexion extension and maintain that posture.
Okay.
So, that would be where I would start. And then I move to the horse.
Yeah, and you just want to use some caution, not knowing how he's going to respond, to start really gentle with that bouncing, not give him too much vestib and input at one time, but
Right, just a real easy
just-
weight shift. You can adjust it. You can control it a lot better than you can control the horse. So it gives you some idea of how much you can tolerate.
Have you ever put a patient on a ball, Lisa?
Yes.
Okay. All right.
Not
And
yet.
then where would we envision her hands would be, or her side walker? Like where are you supporting him as you're moving?
Me right now, I'm
Mhm.
supporting him at his knee and then at his I'm supporting at the side or the back, depending. If he starts to do a lot of that, I'm having my hand in the back so he's not throwing himself back. Mom is doing a light hold on the side, and I'm trying to, I don't know. I think maybe she needs to put her hand behind too with me, so I'm not the only one like trying to hold him up. But I just hold at the knee and then at the back.
Okay. Anybody else have any other ideas of where she could be holding?
Pelvis.
Where's that?
The pelvis.
Pelvis. To-
At the pelvis. That's where I would be. Yeah. I would be at the pelvis. I would have my hands wrapped
More.
around, either side of his pelvis.
Okay.
And, because that's where he needs the control. That's where he doesn't have the control. So, I think the knee's just too distal. It's
Right.
too far away. It's not giving him enough support.
Okay.
So I would come in on the pelvis, and then that way, mom might be able to bring her arm around and be in the back. You just have to see how much extra assistance you needed, or she might just be able to, have a very light support on him.
Okay.
But yeah, that way, if he's coming forward, literally you can help to guide him back up. Or if he's coming back, you can use your thumbs back here and, bring him back forward. So you can have a lot more control of him, so that he's not throwing himself one way or the other. And then if you've got a boppy behind, that just kind of helps, especially with the arm that's reaching around,
Yes.
so that you have a support for your arm, so that you're not going to fatigue and you're not having to worry about your elbow getting into the back of the horse.
That's really what it's convenient for, really. The whole support of my own arm. That leads me to the question, then back to the question about the vest that he wears when he rides. Because I can't access him as easily with that
He
hard
should not be in
So should
any
you have any?
he should not be in anything hard, because what are you giving him? If the whole concept of hippotherapy is to translate the movement from the pelvis of the horse to the pelvis of your patient and move up the spine, you're preventing that from happening. So he's not going to gain anything. So that needs to be removed.
That's
Now,
what I told Mom, but is there any other option out there that's a good?
yeah, something like a Bennick vest. Brianne, your other suggestions?
No, that's exactly what I was going to say. A Bennick, it gives you that kind of compression and some support, but it allows for good movement still. So if the purpose for the TLSO is to keep his trunk in neutral.
Exactly.
I mean, Bennick will kind of help keep that core together and give him, and it also gives him feedback to his body, like especially for low tone in the trunk, that really helps give feedback to help him recruit those muscles. So that actually might be a boost.
Excellent.
To, the hippotherapy portion is, okay, he's, we're trying to get him to activate those muscles. And then the Bennick is there to kind of go, yep, right here, squeezing right here, this part. And that gives us feedback of, yes, this part and where to squeeze and what to, so that I found the Bennicks, the only problem with the Bennicks is they're very hot.
Well, and that's what I was just going to say, is Lisa, I don't remember exactly where you
We're
are.
in
You
Texas,
can't use
I
that
don't
in the
know
heat of
that
the
over.
summer.
They're very hot. They're like a neoprene, they hold in heat and sweat. So it, they're not easy to clean, so depending on the barn and sweaty and horse stuff, you might want to have 2 pairs, which can be expensive.
But, the very minimal support you can use is a good abdominal binder.
Yeah.
At least something that, when you're fitting an abdominal binder, obviously you're going to look at him circumferentially and measure him that way, but it needs to be long enough that it covers his lower ribs and covers the top of his pelvis, so that literally you are connecting his rib cage and his pelvis together.
Okay. Typing
You
this
said the
down.
outside of what his thing is sort of a stretchy material. I'm wondering, is it a Bannock which has like a panel inside or supports inside of it? In which case, can they be removed?
Oh, I see.
Like,
Just use the
I just actually went onto the Bannock website because I was curious, because we're talking about Bannock as like this, it's like a stretchy neoprene compression garment. But it says that they also have a custom trunk support thermoplastic. And so is it a Bannock with like the thermoplastic inside?
Could be.
Oh, okay. So yeah.
In
So
which case you might just be able to slide it right
Like,
out.
the hard part out and just use the
okay.
best. Okay, I'll check
Because
that
it
out.
sounds
I
like
would
mom's
check.
got all the top name, top brand
Yeah.
devices. So it's a very good chance,
That's a
Michelle.
good point. Thank you for picking
Mhm.
that out. I'll double check
I
that.
had a
That
kid
would be
come in,
great.
not in when I was in the clinic, and they had like a Bannock and it had stays and things in it. And I was like, oh, look at that. That's sort of cool. And
Mhm.
that was appropriate for that child who was paralyzed. I don't remember exactly what level, but yes, she needed full trunk support. And abdominal binders, you can even sometimes find them on Amazon,
Okay.
even the pediatric sizes these days, and they can be fairly inexpensive as opposed to, and cooler than a Bannock. So easier to put on.
Okay.
Yeah, just not offering as
I'll
much
try that.
support, but
Right.
certainly.
Doesn't give as much. It does from the bottom of the rib cage to the pelvis, as the Bannock does come up over the shoulder. So
Okay.
Is his G-tube a button or does he have the hose coming off of it?
It's a button.
That's easier. I mean, I think most of the Bennocks they cut out for the G-tube.
Oh, wow.
I mean, for the button, they actually cut a hole in it. The kids that I have.
I also like the binders for kids with G-tubes, because then you stick the binder on and it prevents anything from catching or pulling or anything on the G-tube by accident.
He's I'll see him Thursday, so I'll look into the Bannock, see if that's what that is. I'm gonna send a message to mom. I'm writing all this down in my notes here on my pad, so if I'm looking down, I'm typing it all. So I make sure I get all the information to ask mom as well. It's been so good. This is so way more involved than the majority of the kiddos I see at my barn.
Oh, absolutely. And yet, like I said, everything is relative. He's so much better than the video of the child that I looked at today.
Amazing.
So, I mean, kudos to everybody who's worked with this boy, because he is doing remarkably well given his diagnosis.
Amazing mom. Amazing mom.
Yeah. Yeah. All right. Well, hopefully we have given you some food for thought, Lisa.
Yes, a lot. And it's recorded, right? So I can go back and
we will look. Yes. Well, we will look forward to a update.
Sure. Yeah.
With the things that you try and the things that you learn and all of that. Does anybody have a topic or a patient that they would like to discuss next time? Andrea, surely you have somebody. You're muted.
Back again. I would love that. Yes, I have.
Okay, awesome. Well, just be in
send you a
touch
few
with me and let
ideas.
me know, and that so that we can be, letting everybody else know. But that would be perfect to have, one of your cases, and then, and then maybe start out with Lisa's kind of giving us the update, and then moving on to another child. So in looking at.
I just wanted to say one thing real quick. We never got to really talk about TAC with Lisa's patient, and I'd be curious to see what he would do with stirrups. It could be terrible and backfire, or it might give him like a contact to drop his legs down more. And also maybe he would use it for a little support, which might help pelvic position and possibly trunk too. So I would just be curious if you could attach, if you have the kind you could attach to the bareback pad or something, and just, I would be curious to see how
So good points, both from the pro perspective and the support perspective. I would say the things you need to be careful of is, one, you're probably gonna need to be supporting them, and so it's going to take your hands away from being up here if you got to have your hand at the stirrup. And two is you got to look at where your stirrup is attached, because remember, with bareback pads, oftentimes where you're attaching the stirrups, it's too far forward. And so you want to make sure that they're attached at the place that's going to allow that lower leg to literally drop from the plumb line. The plumb line should go from the hip to the ankle. So you don't want the feet too far forward, because that's only going to put them in the posterior pelvic tilt again. So, but
in my
that
mind,
is certainly
on a mag-
something to be.
on a wedge and an anterior tilt and the
Yeah.
stirrups,
Yeah.
the perfect world, but
Right. Yeah, with the right amount of support up here. But yeah, it is certainly another piece of equipment to think about from the perspective of if he's given that little bit of extra proprioceptive input, would that give him a little bit more stability? So
I had one other tack thought, and this depends on if he has limited abduction, and if part of that flexing up is because of the limited abduction, the saddle can also be a little higher and a little narrower sometimes, and can also help with some of that anterior tilt. I'm treating someone who had hip surgery, and previously she sat on a bareback pad, no problem. But she has really limited abduction.
Yeah.
And we slowly increased. We were using a equisizer, adding pads every couple of weeks to slowly increase the width until we could, because I couldn't even get her on a horse at all. But then we also decided to try a saddle, a very narrow saddle.
It must be narrow, because that would be hard.
Well, the horse, this was a narrow horse too. Narrow horse, but she couldn't even get on the narrow horse. But by being up a little and with the stirrups and the anterior tilt, like the saddle helped her, and that worked much better.
Okay.
Something to
So yeah, so if you had the appropriate sized saddle, which would be very hard, you're going to need some kind of really supportive saddle, like a all-purpose or something that's got a high cantle. That's really given support, but that would then eliminate the issue about where are the stirrups attached if you're wanting to use stirrups.
Yes,
true. Okay.
Isn't the English saddle narrower?
What's that?
Isn't the English saddle narrower?
Narrower, yes. So you are giving a narrower base of support if you choose to use an English saddle. But theoretically, because it sits a little up higher on the horse, it potentially gives you a little bit more exaggerated movement, kind of like the mast of a sailboat.
Yeah.
Yes. Okay, that's good. Well, thank you, everybody. This is amazing. I really appreciate it.
And Lisa, we'll love for you, to give us any updates, any information that you learn, like again, you're on the Facebook group page, right?
Yes.
Yeah, just update for those who attended the case studies meeting. Plus, we're being videoed, this is being recorded. So there are going to be more people seeing this subsequently. There were people who couldn't be here who will be watching this afterwards. So a lot of people will be wondering, what
I'll update on the helmet.
Yes. We definitely want them to know where to get a
Maybe
custom
special
helmet.
helmet, but the way she said was it's a custom helmet, but maybe she just meant it was ordered special or something. I don't know.
Well, whatever it was, if
it
it's something unique or different that most people wouldn't know about, we'd love to have our options open for sure.
For sure. Okay. Sounds good.
How does Monday, May 20th look to people for the next meeting?
For me, that's our end of the year horse show for our skilled day program is the 30th. So we're on kind of go time.
Is the 20th not going to work for you then? Is that what you're saying?
For for me. But maybe only for the case study piece of it. I could do that in the next one for sure.
Okay, so I will need a new topic. Anybody else have a patient they would like to discuss?
I have another rare syndrome, very brand new, haven't mounted the person yet, but I do know it's a very rare. I think it's another trisomy, but if nobody else.
Is it a trisomy 18?
I think it's something even different. I mean, literally, I just got the phone call. And
Okay, well,
had the
Lisa, just be in touch, because otherwise I'll have to put out a request, or if anybody else, is interested, just reach out to me and let me know.
Okay.
Because obviously we need to have a topic, but we'll at least tentatively put it down for the 20th, and I'll just kind of wait to hear from people, or I'll put out a request for.
And
another
Carol, I
topic.
could volunteer possibly one of our PTs who's not going to be as stacked up as I am during that week, if that would be an option.
Well, if you want to talk with her and let me know, sure, that'd be great. Thank you.
Absolutely.
All right. Thank you, guys. It was good to see your faces again, those of you that I didn't get to see at conference. And I will look forward to seeing you next time.
Thanks. Bye.
Thank you.
All right. Bye. Thanks again,
Thanks so
Lisa.
much.
Oh, thank you.